All right, so intubation process. What is intubation? It means I'm putting a large size tube down your throat through your vocal cords into your trachea. If you've ever had surgery before and you woke up with a sore throat, you probably had a breathing tube or an intratracheal tube down here. We don't do this to be cruel. We do this because we need to take complete control of your airway. We need to protect your airway. You're not doing it yourself. When you have surgery, we give you medications, put you to sleep. Sometimes we actually chemically paralyze you. So we need to take complete control of your breathing, and we do that by intubation. The next video you're going to see will show the whole process. It's actually a real patient during intubation. After that, I'm going to demo what we call a tomahawk intubation. So I'm going to take a little different level outside this controlled environment. So sit back and y'all, hopefully you're taking notes. All right, take notes during all of this, please, especially PA students. You're going to be going on rotation. You've got to know these things. I can't tell you for how long I carried a little notepad, all right, for years until I had really memorized of what I needed to do. All right, so take notes, please. It's going to bail you out. Let's go from there. We've got the video coming up.
Is an important part of airway management. It is best learned through practice under expert supervision, in our opinion, first on a mannequin and then on elective, uncomplicated and fasted patients. This lesson aims to prepare you for these practice sessions, and our narrow focus is teaching the manual skills that will increase your chances of success. Your intubation should always be preceded by an airway assessment. What equipment and personnel does the patient in front of you require? Are there complications you suspect may arise? And is everyone on board with the plan if they do? First, place the patient in an optimal position with the pillow tucked underneath the shoulders. Raise the head relative to the body into the so-called sniffing position. Your goal is to achieve a line of sight to the vocal cords in order to pass the tube through them into the trachea. This requires a laryngoscope. We will teach the traditional direct laryngoscopy, but for filming purposes, we use a video laryngoscope that has the same shape. Have the patient inhale 100% oxygen through a tight-fitting mask. When the measured expiratory or end-tidal oxygen concentration exceeds 80%, you've loaded up an oxygen reserve in the periphery of the lungs. If this monitoring is unavailable, pre-oxygenate for a minimum of 3 minutes. Pre-oxygenation can be further improved, especially in the obese, by tilting the table and by applying a positive end expiratory pressure. This extra oxygen in the patient buys you potentially life-saving time if you have unexpected airway difficulties, precious time to call for help, or try more advanced techniques. Administer the analgesic and await the onset. Laryngoscopy is very painful and requires drugs to alleviate sympathetic response and airway reflexes. Next, administer the hypnotic. The patient gradually loses consciousness, airway muscle tone, and respiratory drive. From this point on, the patient's breathing is your responsibility. A paralytic facilitates intubation. Traditionally, we would first have confirmed successful face mask ventilation, but no evidence has shown that this prevents airway complications. Therefore, the emerging consensus is to administer it as soon as the patient is unconscious. Open the airways. A 2-finger chin lift may be all it takes. If this isn't enough to be able to ventilate the patient, the next step is a jaw thrust. Open the patient's mouth with your thumbs on the patient's chin and place your fingers firmly behind the angle of the mandible and lift straight up in a decisive manner. Successful ventilation is confirmed by observing the chest wall rising and regular end-tidal CO2 waves on the monitor. If you cannot ventilate the patient at this point, you need to use other equipment and techniques that we will demonstrate in forthcoming videos. While you wait full onset of the drugs, take a moment to make sure that you have achieved absolute optimal positioning before proceeding to laryngoscopy. Do not forget that while you may hold the blade, This is very much a team effort. Open the patient's mouth with your right hand and hold the laryngoscope in your left. Not too tight, with 3 or 4 fingers as close to the blade as possible for precision and control. Insert the blade in the right side of the mouth, carefully pushing the tongue aside. The aim is to create an unobstructed line of sight to the larynx by pushing the tongue to the left and lifting the epiglottis, exposing the vocal cords. This requires precision, not brute force. A common mistake at this point is leaning forward, as it feels this will give a better view. It doesn't. Stand upright with the left arm at a 90-degree angle tucked in towards your body. This allows for better ergonomics, better communication with the team, and a better overview of the ventilator, the timer, and the patient. Let's see the laryngoscopy once again. Advance the blade until you see the epiglottis and place the tip in the vallecula, the recess at the base of the tongue. At this point, you can start to apply some force in the direction of the laryngoscope shaft. Sometimes a light external force on the larynx can make the vocal cords spring into view. Ask for your assistant's hand and move it to apply backwards, upwards, rightward pressure, or burp for short. Make sure you don't pinch the lips and do not exert any pressure on the front incisors. By now, you hopefully have a clear view of the opening of the trachea, a dark slit between the pale vocal cords. Insert the tube carefully. Sometimes a gentle rotation is required to pass the vocal cords. Advance the tip until the cuff has disappeared and the vocal cords are between the 2 black lines. Ask for inflation of the cuff and carefully retract the laryngoscope. Hold the tube firmly while you confirm that it's lodged in the trachea and not the esophagus. The gold standard is return of end-tidal carbon dioxide over several respiratory cycles. Be very cautious when interpreting the other signs traditionally used. Auscultation finds on both lungs, condensation in the tube, and the symmetric rise of the chest wall, as these may very well be positive despite an esophageal intubation. When you're absolutely certain that the tube is in the trachea, secure it with tape and initiate mechanical ventilation. Congratulations, you have now performed an endotracheal intubation. For more videos on anesthesia and critical care, go to interanes.org or subscribe to our YouTube channel.
All right, let's talk about a couple other things here as far as innovation. All right, so I mentioned on the video that we're going to bag them. All right, so when I say bag, we're going to be basically breathing for them. What we're doing is we're denitrifying them. What is denitrifying? Basically 70% of the air that we breathe is nitrogen. Roughly about 20–21% is oxygen. We're replacing all that extra air in our airway with 100% oxygen. All right, so I'm pushing that nitrogen out. I'm replacing it with 100% oxygen. That gives me the ability to maybe take a little bit longer to intubate. Maybe you're not going to be an easy intubation. The first time you do this on someone, you're going to be nervous. You're going to be scared to death. If you're going ER rotations, it's really not in a controlled atmosphere. If you're pre-hospital, and you're doing that type of medicine, it's in a really uncontrolled atmosphere. So I need as much time as I can. So I'm replacing that nitrogen that sits in my mouth and my trachea and everything else with 100% oxygen. So we're denitrifying. When you're bagging people, when you're breathing for them, it's not, all right, we're not spazzing out. It's slow, one breath every 3 to 4 seconds, all right? And I promise you, when you do this, you're going to be really nervous. You're going to hyperventilate. You can actually cause barrel trauma. You can damage your lungs by doing this too much. I can actually tell you on the SWAT team, we're getting rid of the adult size and going to pediatric because they're getting enough oxygen, it's being fine, and we're not going to damage people. All right, so Ambu Bag Bagging. This is called a bougie, okay? A little bit closer. UPA students, this has bailed me out more than once in a difficult intubation. This is your keeping your bag, keeping your pocket. This is CYA. This keeps you out of court. This helps you a lot. All right, so what a bougie is, and I'm going to demonstrate here in just a second, is I'm going to slide, as I actually go into the mouth to look, All right, I'm sliding, instead of the actual breathing tube, which is this, I'm going to slide the bougie in first, and I'm going to demonstrate here in just a second. You'll see the advantages behind this. I promise you this will be your best friend. Bruna can attest to this. This can easily save your career and save a life. All right, at the end of this, the reason why it's curved at the end of that is that actually you can feel the tracheal rings. As you're going into the trachea, I'm feeling this bump off the tracheal rings of my trachea. So it's sliding down, it's like little speed bumps. I can go back and forth and kind of know, yeah, that's trachea. The esophagus is smooth. So if I'm in esophagus, I won't feel those tracheal rings. All right, so what you saw on the video is a nice controlled environment, right? So you're in the OR, everything's quiet, they're playing music, they give you nice medications, life is good. That's not always the case in real life, all right? ER, when you're out in the middle of nowhere, let's say you got multiple people coming in. Let's say that you go to an accident scene, right? For EMS, you've got an entrapment. I've been in many accident scenes where the extrication time, which means the time to get you cut out of the car or cut the car around you and get you out, maybe an hour and a half to 2 hours. You're trapped inside that car. I've got to take control of your breathing because you're starting to crash on me. The only way to do that is do it while you're still sitting in your car seat. So it's called tomahawk intubation. They don't teach us anesthesiology. They don't teach us anywhere else. It's just a technique that we've learned pre-hospital wise. All right, so basically what this right here is going to be simulate the hood of the car, okay, or whatever else. It could be in a collapsed building. It could be somewhere that I can't get to the victim. You see the victim over here? Let's just simulate that they're still strapped in their car seat. I cannot get to them because literally they're entrapped. All right, so I'm gonna get all my equipment ready. Get on the car, the hood of the car. All right, so tomahawk intubation. The reason why we call it that is because we're holding this like a tomahawk. Okay, so what I'm going to do is I'm going to get down in here, and I'm looking for the same thing you saw on the TV or the video. I'm looking for the vocal cords. All right, I'm getting in, pulling back the epiglottis, sliding this down. All right, I can feel the tracheal rings. Once I get that through, I'm going to take the endotracheal tube, breathing tube, and I'm going to slide this over it. All right, pass it all the way down. PA students, all right, 21 to 22 centimeters at the lips. These have got numbers on there. Is about as deep as you want to go. That way you get in the right place. If you go any deeper than that, you call what we call main stem intubation, so you're actually going to the right lung. You only get one lung inflated. I'm going to demonstrate that. If I go too deep, you'll see the lungs down here. You see this one lung inflating, the other one is not. Let me inflate the cuff. So at the end of this breathing tube is basically a balloon. I'll show it after we pull it out. All right, so I'm going to inflate this with about 6 to 8 cc's of air. This is a push. All right, so now you'll see the one lung. I'm getting a little bit on the other side, but more on the right. All right, that's too deep. So I'm going to pull back out a little bit. I'm going to deflate this so we do not traumatize the trachea or our windpipe. And now I'm going to go ahead and breathe for them. Both lungs are inflating. I'm going to slow my breathing weight down. My best indication for good placement is several different things. First thing is actual visualization. I actually physically see my bougie pass through the vocal cords. I saw it. I know it's not anywhere else. The second thing is going to be end-tidal CO2, end-tidal capnography. So if you think about this, we exhale carbon dioxide. It only comes from our lungs, right? Not our stomach. We may get a little bit from our stomach if we just drank a Diet Coke because of the carbonation, but you don't get actual waveforms. We've got caps that actually go on the end of this. It'll change colors. All right, so every time they exhale, it'll change colors. Yellow, yes. All right, so if it turns yellow or gold, it's yes, you're in the right place. That means it's actually sensing carbon dioxide. It's got to be in the lungs. The other thing is we're going to auscultate. We're going to listen. So when we listen to both lungs, all right, and the stomach. All right, you're going to go down and listen actually to the stomach area. So both lungs and stomach, you hear gurgling inside your stomach if it's in the wrong place, if it's in your esophagus. We call it tubing the goose. If you tube the goose, it's no bueno, all right? There's many people out there who they swear they got them intubated. I know it was in the right place. No, they're in the stomach. All right, that won't save a life. The other thing is condensation in this tube. Every time they exhale, there'll be some condensation. So it'll be there, and when we bag them again, it goes away. Okay. And the last thing for you PA students is get a chest X-ray. That's what's going to hold you up in a court of law. All right. So get a portable chest X-ray, no confirmation. That way you can look at it and go, yep, there it is right there. Okay. So this is tomahawk intubation. You always tape this down. All right. I let go of it because I stood up, and if this was real life, I would never let go of this until it was actually taped. Because all it takes is for someone to not paying attention, and all of a sudden you yank it out and you just start it over. Okay. You've got to secure this with either tape or a tube tainer. Let me show you this cuff at the end of this breathing tube. Why is this important? Well, we're actually putting air through the middle of this. This seals it up against their trachea. All right, so if they do vomit, which they will if this is the code, it's going to slide down and it's just going to sit. So this is our trachea. It's just going to sit on top of here and never enter their lungs. Okay. We can suction this out from here, but if it gets past this and get in their lungs, then we've just lost air. We've just introduced foreign stuff, stomach contents, everything else in your lungs. It's called aspiration pneumonia, and you'll spend a while in ICU if you ever get out. All right. Stomach contents and lung tissue don't go real well together. All right. Laryngoscope. Handle, blade. It's not sharp. Right? I say blade, but it's not. And a light. Always, always, always check your equipment. Most of the newer stuff is fiber optic. It doesn't have these bulbs, but there's a bulb on the end of that. All right. Check and make sure it's tight. Aviation and medicine have all been learned by blood. Okay, which means we've made mistakes. We've learned from them, we've moved on. Aviation, same thing. Oh, that didn't work, they crashed and died. Let's fix this. Same thing with this bulb. Someone along the lines, this was loose, they went to intubate, and the bulb fell off inside the mouth and went down into the lungs. So what we do, we change our practice. Evidence-based medicine, we make sure these are tight, make sure the light's good, it doesn't turn on and off. The curved ones for UPA students are called Mac blades. The straight ones are Miller blades. I don't have a straight one out here, but it's just straight. This is a number 3. Can't see it on it. Mac number 3. That's my favorite one. Okay. Endotracheal tube. What size do we use? Most adults are going to take 7, 7.5, 8. Pediatrics, it's a specific formula, which you'll learn down the road. All right. Bougie. B-O-U-G-I-E. Okay. Ambu bag, just say go ahead and bag them. This is what they're talking about. Okay. When you bag them, you're using a C. So I'm making a C, grab underneath their chin. So we're automatic. You see the lungs. Now keep in mind too, when I'm bagging them, air's going in their lungs and it's also going in their stomach.